I am Dr. Raj Makkar from Cedars-Sinai Medical Center in Los Angeles. Well, transcatheter aortic valve replacement has become a very acceptable treatment for patients with aortic stenosis based on pivotal randomized clinical trials that have been done in the last decade. But however, these trials excluded bicuspid aortic stenosis anatomy. So in young patients, as we are treating more and more younger patients, almost 50% of these patients have bicuspid anatomy. It is therefore imperative that we have more data on the use of TAVR in patients with bicuspid aortic stenosis. In the United States, all transcatheter aortic valve replacement procedures are registered in a registry. It's called the STS-ACC-TVT registry. So this data set essentially provides us an opportunity to look at all patients with TAVR, including patients who had bicuspid aortic stenosis and underwent transcatheter aortic valve replacement. So between 2015 and 2020, there were almost 150,000 patients that underwent transcatheter aortic valve replacement with the balloon expandable SAPIEN 3 or SAPIEN 3 Ultra valve. And of these, more than 30,000 patients actually were low risk for surgery. Our primary goal here was to see what are the outcomes of transcatheter aortic valve replacement in patients who have bicuspid aortic stenosis and who are low risk for surgery. So essentially, in the entire data set, there were more than 7,000 patients with bicuspid aortic stenosis, and more than 3,200 patients actually were bicuspid aortic stenosis and were low risk for surgery. We looked at the outcomes of TAVR in these patients, and we compared them to the outcomes of patients with tricuspid aortic stenosis by performing what is called a propensity one-to-one matching. What we found was that in these low-risk patients, where the average age was less than 69 years, both for bicuspid and tricuspid aortic stenosis, the STS was 1.7, which means that the expected mortality was 1.7% at 30 days. When TAVR was performed, the outcomes were actually quite good. The intra-procedural outcomes were good. In hospital mortality in patients with tricuspid aortic stenosis was 0.6%. Compared to 0.4%, in patients who had tricuspid aortic stenosis. Similarly, the stroke rates were around 1.2% in both bicuspid and tricuspid aortic stenosis. So similar outcomes in terms of death and stroke were also seen at 30 days and 1 year. So at 30 days, the mortality from TAVR or mortality in patients who had undergone TAVR with bicuspid aortic stenosis was 0.9%. So this is pretty good. This is, comparing it to patients with tricuspid aortic stenosis and comparing it to the published literature with surgery with bicuspid aortic stenosis, our conclusion was that at 30 days, these outcomes are quite competitive. In addition, looking at the mortality and stroke rates at 1 year, once again, what we found was that the mortality with bicuspid aortic stenosis at 1 year was about 4%. And similarly, with tricuspid aortic stenosis, it was about 6%. So our conclusion is that these endpoints of death and stroke are similar between bicuspid and tricuspid aortic stenosis in patients who are at low risk for surgery. The intra-procedural outcomes, including conversion to open heart surgery, were very low in these patients. Similarly, the rates of reintervention after bicuspid aortic stenosis were also quite low, after TAVR. We also looked at the echocardiographic outcomes, which is the gradients and the valve areas, and they were similar. We also looked at the functional measures, which is quality of life, in terms of the improvement in KCCQ scores and the improvement in NYHA class, and they were quite impressive and similar between bicuspid and tricuspid aortic stenosis. Indeed, at 1 year, almost 95% of the patients that had undergone TAVR for bicuspid aortic stenosis were in NYHA class 1 or class 2. So I would deduce that based on these results, we feel that, in selected patients, TAVR is actually a very reasonable alternative to surgery in patients with bicuspid anatomy. So the way TAVR is performed in the United States is with a heart team approach. Specific anatomical characteristics were not collected in the TVT registry, and we do know that morphology can play an important role in the outcomes of TAVR after bicuspid aortic stenosis. So that, in a way, is somewhat of a limitation of this study. But nonetheless, what can be said is that if the heart team decides, after evaluating clinical aspects of the patient and the imaging characteristics of a patient, at least in the United States, in this consecutive series of patients, when TAVR was performed, the outcomes were actually quite good. I think we need to gather more data precisely to guide what anatomical characteristics should dictate that patient undergo TAVR versus surgery. We have performed one such study, but I think we need to do further work in that area. And finally, I do believe that it would be ideal to do a randomized clinical trial between surgery and transcatheter aortic valve in patients who have bicuspid aortic stenosis and who are at low risk for surgery.